Very good afternoon. Welcome. Wishing you all happy, healthy, prosperous New Year 2025. This is the Indian Medical Association, Academy of Medical Specialties. So this is the first webinar. Welcome everyone. This is the program. Today we are going to do the three important topic discussion. And this is the, we have a new office leaders, national office leaders. Dr. Dilip Bansali sir, he is the national president. Welcome sir. Dr. Sarbari Datta ma'am is ma'am is the honorary general secretary, and Dr. Ramnik Singh Bedi sir is our IMA AMS national chairman, and Dr. C. Sairam sir, our secretary of IMA AMS national headquarters, and our vice chairman of AMS, Dr. V. Amudan sir, and our new president of IMA state branch, Dr. Sengutuvan sir, and President-elect Sridhar sir, and all the leaders of our IMA. Very good afternoon. Welcome to this first webinar of IMA AMS. So today we have a galaxy of speakers and moderators. We are all going to.
I welcome you all for this first CME program, which is being conducted by our IMA AMS Tamil Nadu in particular, mainly from the IMA AMS. We welcome you all. First of all, I like to welcome our National President Dilip Bansali sir, and the National Secretary, the Sarbari Datta madam, and our National IMA AMS Chairman for the year 2025, Ram Nikhil Singh sir, and our Secretary of IMA AMS, Dr. Sairam sir. And also, I like to welcome the National Vice President of the South, the Alex sir, and the National IMA AMS Vice Chairman, Dr. Amudan sir. And I like to welcome our office bearers, our State IMA President, Dr. Sengutuvan sir, the immediate past President, Dr. Abul Hassan sir. I like to welcome Dr. Sridhar sir, the President-elect 2025, and our State Secretary, Dr. Karthik Prabhu sir, and our Treasurer. I welcome you all for this program. And today we are having three programs. One is about the Cervical Cancer Awareness Month, which is January, and the Road Safety Week, which is observed from 11th to 17th of January 2025, and also the National Leprosy Day, which is falling on 30th of January. These three things, we wanted to give some lectures about it. So I welcome the speakers of the day, Dr. Indra Nedumaran, Dr. Dinesh Kumar, and Dr. Raghunandan, and the moderators of the day, Dr. Anbarasi Kumaresan, Dr. Pavitra Gunasegaran, and Dr. Ram Mohan. See, actually in IMA AMS, we are having a lot of programs. Every month we are planning to conduct this CME on the first Thursday of every month. We will be having a Zoom meeting. In that meeting, we will be having all the days of the month program we will be having. And then we are having, we are actually, when we have got installed this year, we have told that we are going to have a 10 commandments, and everything our secretary will be telling in brief. And we will be starting, already we are conducting around 6 courses. We will be increasing the number of courses. So I welcome you all for this program, because we are having 3 topics. We have to run one by one fast. Thank you one and all. Welcome you all for this CME.
We'll move on to the CME program. May I request our Adar Sandil Kumar, Joint Secretary, to take over and start the CME session. Shall we go on to the CME session, sir? Chairman, sir,
Yes, sir.
Yeah, please, sir, please.
Yes, sir. Thank you, Dr. Jayaraman, sir. So we will move on to the today webinar. The first topic is the cervical cancer prevention. moderated by Dr. Anbarasi Kumareshan and the speaker, Dr. Indra Nedumaran. I am pleased to introduce our moderator, Dr. Anbarasi.
Now you can share your screen, ma.
Yes.
Yeah, right. Coming.
Okay.
Yes.
Dr. Anbarasi Kumareshan is a senior radiation oncologist from MGM Cancer Institute. She studied MBBS at Thoothukudi Government Medical College and DMRT from Cancer Institute, Adayar, Chennai, and MD Radiation Oncology from Cancer Institute, Adayar, Chennai. She was the best outgoing student in Department of Radiation Oncology in the Cancer Institute in the year 2015. She received Dr. Jagadishan Award from Association of Radiation Oncologists of India, and she won the first prize in the Grand Oncology Quiz Contest at Indo-UK Oncology Summit 2013. She received award from the Association of Radiation Oncologists of India. She authored in many chapters in various medical textbooks, and she published in many journals in the national and international level. We welcome Dr. Anbarasi Madam. Kindly introduce the speakers and go to the session. And Dr. Anbarasi Madam, over to you.
Good afternoon to everyone. So I'm as an oncologist today, I feel very happy that you have introduced one oncological topic, especially the cervical cancer prevention. So you once upon a time, because like from before 5 years, the most common cancer was cervical cancer, but now it has moved on to the second common cancer. As per the Globocon 2020 data, in India, daily 350 patients are getting diagnosed as cervix cancer. So, as per the same data, for every 4 minutes, one patient is diagnosed to have cervical cancer. For every 7 minutes, one patient is dying due to cervical cancer. So, today, Dr. Indra Nedumaran is going to talk about the cervical cancer prevention. So, which is the much needed topic now. Dr. Indra Nedumaran she is a senior obstetrician and gynecologist in MGM Cancer Institute and MGM Healthcare, and she is also a founder of A to Z Pregnancy Care. Apart from regular practice of obstetrics and gynecology, she is specially interested in doing many public health camps and peripheral health camps to detect cervix cancer. She has been a part of HPV screening project in the government hospital along with the Rotary. She has won a Best Doctor Award from Tamil Nadu government. She also won Urvasi Shah Award for the best paper at ACOG conference. So it's a great pleasure for me to introduce Dr. Indra Nedumaran. Over to you, ma'am. You can start your presentation.
Year to all. I think January is a month where we need to do awareness on cervical cancer. I think we have an hot topic of prevention of cervical cancer. So basically, in this presentation, I'll talk about the etiology, risk factor, and the way how we can prevent the etiology, and then how we can detect precancerous lesion and how we can prevent cervical cancer. So the first slide. So every year, more than 300,000 women die from cervical cancer. So you can imagine the global burden. 80% of cervical cancer deaths occur in low and middle income countries. The reason for this high mortality is a poor access to prevention, screening and treatment. It contributes to 90% of the death. And the thing is, cervical cancer is preventable and treatable if caught early. So, I think the key word lies there. The only etiology for cervical cancer is human papilloma virus. I think everybody knows about it now. I think past a few years, a lot of awareness program is going on, public as well as everywhere. So we know human papilloma virus is the only cause. So there are low risk and high risk viruses there. I think low risk virus, we see viral warts, especially 6 and 11. And other viruses like 16, 18, 31, 58, all those things, we have high risk viruses which causes cervical cancer. So if you see 16 and 18, more than 75% of cervical cancers are associated with the 16 and 18 viruses. So HPV virus not only causes cervical cancer, the other cancer caused by human papilloma virus are vaginal cancer, vulval cancer, anal and throat cancer. So and penile cancer in men. The risk factor for cervical cancers are early marriage, sexually becoming active at young age, having multiple sex partners, history of smoking, multiple pregnancies, and weakened immune system. I think we have people who we are seeing cases who has gone transplant on immunosuppressants and who had a HIV, so immunodeficiency virus. So these people are having an increased risk of having a cervical cancer. HPV infection. So what it does, usually HPV infection is occurred through sexual contact. So usually the HPV virus have a E6, E7 protein. So that binds to P53 and retinoblastoma inactivation gene, which is there in the cervical cells. So this will lead to cervical cancer. So we'll see how the pathogenesis happens. So usually when the persisting, usually I think all the viral infections, what we do, I think we have learned in COVID, if you occur any viral infections, 90% our immune system will push it out. We'll be able to cure by ourselves. Only 10% they go into trouble. So like that, people who occurring HPV infection, 90% of them will get cured by themselves, but 10% it stay as a persistent high risk HPV infection. So the HPV integration happens. So overexpression of oncogene E6 and E7. So it integrates to retinoblastoma gene and inhibit P53. So when E6 integrate to P53, so it causes aberrant proliferation and differentiation. I think everyone knows that when there is I think any cancer growth, the aberrant proliferation and differentiation is the main reason for the carcinogenesis. And again, our natural thing is apoptosis to prevent any abnormal cells. So this E6 protein inhibits apoptosis inhibition. The same thing, it's a silencing of tumor suppressor gene. And it causes E7 causes cell cycle dysregulation and chromatin reformation. So all these things leads to progression of cervical carcinogenesis. So basically, the integration of E6, E7 to P53 and retinoblastoma inactivation genes causes it is a starting process of your cervical cancer. So if you see the cervical cancer, so actually gives, I think in this world, no other cancer gives so much opportunity for prevention. The cervical cancer, so usually when the infection comes, so usually the cells integrate into the cervical cells, it causes pre-malignant lesions. The pre-malignant lesion takes 5 to 15 years to change into cancer. So we have so many things for prevention, so many opportunities. See, actually, the vaccine, we have a HPV vaccine. We have a very good screening modalities available for detecting pre-malignant lesions. Pre-malignant lesions will be there 5 to 15 years. So it takes 5 to 15 years to change into cancer. So we have enough time, ample time to treat. The treatment modalities are, we have cryotherapy, pottery, and we have a laser treatment, and we have loop excision. So many options available. So prevention, I think we have learned in community medicine. So we have a primordial prevention, primary prevention, and secondary prevention. Primordial prevention, reduce the risk factor. How to reduce the risk factor? You make the public aware about the risk factors for cervical cancer by making awareness program and making the public aware about it, so we can reduce the risk. How to do public awareness program, school education program, menstrual hygiene awareness program, and quit smoking. So I think I always feel that when you want to make an impact on anyone's mind, so better to catch during the teenage time. So the school health program is supposed to be a very good opportunity for us, especially IMA, so we can take a lead, so we can do that program. So by making the kids aware about the risk factors, it may play a major role in prevention of cervical cancer. So what a global strategy to accelerate the elimination of cervical cancer as a public health program, November 17th, 2020. So I think WHO made a strategy. So there's called a global strategy to eliminate cervical cancer. What it says, this global strategy to eliminate cervical cancer proposes a vision, a world where cervical cancer is eliminated as a public health problem, a threshold of 4 per 100,000 women years for elimination as a public health problem, the following 90-70-90 target that must be met by 2030 for countries to be on the path towards cervical cancer elimination. What is the 90-70-90? 90% of girls fully vaccinated with HPV vaccine by the age of 15 years. 70% of women are screened with a high performance test by 35 years of age and again by 45 years of age. 90% of women identified with the cervical disease receive treatment. Especially 90% of women with the pre-cancers treated and 90% of women with the invasive cancer managed. A mathematical model that illustrates the following interim benefits achieving 90-70-90 target by 2030 in low and low middle income countries. Median cervical cancer incidence rate will fall by 42% by 2045 and by 97% by 2120, averting more than 70 million new cases of cervical cancer. So we'll be able to achieve an elimination of cervical cancer by following this strategy. I was very happy Dr. Saira was saying that I think our government is taking forward and putting it in our national immunization program, the HPV vaccine. So it will be like a very step forward for our public health. Primary prevention. I think we have past experiences with the smallpox. We have eradicated smallpox. Again, we have almost eradicated the polio. So that is because we know the etiology and we had an effective vaccination against the disease. The same thing, HPV, human papilloma virus. We know the etiology for cervical cancer is human papilloma virus. We have an effective vaccination. So we need to use it effectively to prevent that. So I think as all the IMA member people who is attending this month, January month is a cervical cancer awareness month. In your OPD, you can keep a pamphlet or you spare 2 minutes if you have time to all the people who is coming. Make sure they know how the cervical cancer is caused, the etiology of cervical cancer, and regarding the vaccine and the availability of the vaccine, the importance of getting vaccinated. I think when you are seeing a patient, you can spare 2 minutes of your time to teach about that. If you're not able to, when the people are sitting in the OPD, maybe you can ask your staff to have a talk or something regarding the prevention of cervical cancer and importance of HPV vaccination. So by doing that gesture, we'll be making a big impact on the society. So the different type of vaccinations are available. We have bivalent vaccine. Bivalent vaccine is not available now. It has been away from the market. So we have a quadrivalent vaccine. Quadrivalent vaccine have 16, 18 and as well as the non-high risk cases like what's producing viruses 6 and 11. So for those 4, it is covered by quadrivalent vaccines. There are 2 vaccines available. One is by the MSD. The other one is our Serum Institute. Our own vaccine also has come to the market, is available now. And a nanovalent vaccine. Nanovalent covers 7 high-risk viruses and 2 low-risk viruses. Nanovalent vaccine, only one company, or monopoly, only one company only has that, but it's a quite cost. But the thing is, the experiences are, like we were talking only about 16 and 18 causing around more than 75% of cervical cancer. But we may not know other 10 years down the lane, 15 years down the lane, 20 years down the lane, we may other viruses also emerge as a increased risk of cervical increased association with the cervical cancer, because when we are doing core testing, we are seeing other viruses also, not only 16, 18. So we are seeing other high risk viruses also when we are doing a HPV screening. So the time only has to give us the answer. So when you are suggesting a vaccination to a person, you discuss quadrivalent is available, nanovalent available, everything you discuss. Let the person take a decision what they want. That is always better. You don't decide on behalf of patient. Always you tell them, so there is a vaccine, it can prevent cervical cancer. Even if you take a cervical cancer vaccine, you need to go through the screening process once in 5 years after they become sexually active. So that message has to be passed on to them. So then only we'll have a long-term data, and then we'll be. So vaccination, storage of HPV vaccine, all HPV vaccines stored at 2 to 8 degrees Celsius, not frozen but protected from light. They should be administered immediately after removal from the refrigerator. It is very important. Suppose when you are in your clinic, when you are stocking, you want to stock your HPV vaccine and provide, Always better to have a ILR fridge. Without that, don't keep, because suppose if there is electricity fluctuation, if things are there, it is I think it is a major vaccination thing what we are taking and putting it forward. Suppose if the efficacy goes, it will be difficult because it doesn't have any indicator that whether the temperature is maintained or not. We don't have any indicator in the vaccine. So it is better to have a ILR fridge if you are going to have a vaccination center. The vaccine is available in 0.5 ml dose. It should be given intramuscularly in the deltoid region. The individual should be treated during vaccination and observed for 15 minutes after vaccination. I think any vaccination, you follow the same protocol. The Foxy HPV vaccination recommendations are optimal dose, 2 doses 9 to 14 years, at least 6 months apart, 3 doses above 15 to 26 years, 0, 1 to 2 months and 6 months, 3 doses for older women till 45 years. So these are all the Foxy recommendation. So people will come and ask you, so like I am 42, so shall I take a vaccination? So I think Foxy is telling that so they can also have the benefit of getting vaccinated, because we see HPV, we see cervical cancer, we detect at the age of 60. So sometimes they acquire infection at 40. No, if so far they have not had, they can acquire at any time. So always better to take the vaccination and have the benefit of it. I think WHO recommends other reduced dose because the thing about HPV vaccination is the cost factor. The reduced dose, what they recommend, it is they recommended by WHO, 1 or 2 doses for 9 to 14 years, 1 or 2 doses for 15 to 20 years, 2 doses for 21 years and above. Single dose schedule can be used for girls and boys aged 9 to 20 years. Boys can be vaccinated from 9 to 26 years, 9 to 14 years, 2 doses, and 15 to 26 years, 3 doses. So, if you see the evidence, like the first optimal dose have a level 1 grade A evidence, other things are level 2 evidence. I think so far we have seen, primordial prevention and primary prevention. Now the secondary prevention. See, once the patient has got the HPV infection, the cells got integrated and it formed the pre-malignant lesions. So you identifying the pre-cancerous lesion and effectively treating them will prevent cervical cancer. So the secondary prevention relies on identification of pre-cancerous lesion and effectively treating them with the effective method. So I think this have a this is very tricky. So we need to be very make the person aware, and we need to use lot of resources for this. Actually, it is a manually they need to, every woman has to be screened. So I think my next slide I'll show how often, what are the type of tests are available. See, I think the screening recommendation according to resource setting, this is also by Foxy. What they say, good resource testing, good resource setting, the preferred method is primary HR HPV DNA testing every 5 years. Age group is 30 to 65 years. Suppose the acceptable are cytology every 3 years from 25 to 65 years, VIA every 3 to 5 years. VIA is visual inspection with acetic acid. Suppose low resource setting, because HPV viral DNA detection needs special testing and special laboratories and the cost involved. I think Tamil Nadu government, what they are doing is actually they do visual inspection with acetic acid every 3 to 5 years. So usually the age group target is 30 to 65 years. So once in 3 years they are doing it. So the primary screening are 2 things. One is a VIA, so visual inspection with acetic acid. If it is negative, rescreening 3 years with the VIA test. Suppose if it is positive, see if there is a lesion is there, it is suitable for ablation, do a cryotherapy or thermal ablation. Lesion is not suitable for ablation, go for excisional procedures. And then depending on the histopathology, suppose if the pathology is less than CIN3 or AIS, so they'll go for 1 year follow-up. Suppose if there is no CIN is more than 3 or suspected cancer, they'll go into the treatment stream. Suspected cancer, evaluation, biopsy, and further management. So this is the algorithm used for triage, doing for screening with the VIA. HPV DNA used high resource testing, high resource setting, and it is actually the cost involved is more. So if it is positive, go for VIA because we need to look at the cervix. If the VA is positive, we'll go for ablative treatment. If it is the thing is suitable for excision, we'll go for excisional biopsy. And we follow up HPV DNA positive patients. We follow up every year with HPV DNA till they become negative. Or suppose if there is a VAA also we do. Suppose if there is any lesion coming up, they need to go for treatment accordingly. If it is negative, HPV DNA is negative, we can rescreen 5 to 10 years with the HPV DNA test. So the other type of screening what available is a primary cytology screening. I think now, I think most of our private practice and everybody does this. So we do a pap smear. Sometimes lot of company patients comes every year they come. I think when we see the primary cytology screening, some people they get more frequently tested. Some people who is needed they don't come for the testing only. The disparity is there. When they do a pap smear, so if it is negative, so rescreen in 3 years with the cytology. If shows abnormal squamous cells of unknown significance, so they need to go for further triage. So immediate triage with the HPV DNA test. If HPV DNA is negative, so they'll go for a regular follow-up. If it is positive, they'll go for a colposcopy directed biopsy. If it is LSA, then directly they'll go for a colposcopy directed biopsy. They get a rescreen in 1 to 3 years with the cytology. If it is negative, so they'll get a rescreen for 1 in 3 years. If the ascus is there, again they'll go for a colposcopy directed biopsy. If the CAN1 rescreen after 1 to 2 years, if the CAN2 plus and satisfy the criteria for ablative therapy, ablation with the cryotherapy or thermal ablation should be done. And follow up after every year, and cytology has to be repeated every year. The lesion is CAN2 plus and does not satisfy eligibility criteria for ablative therapy. Excisional procedures, we have a LEDS and a LEE or a CKG should be done, and a follow up every year with the cytology. If the lesion is suggestive of invasive cancer, further evaluation and management based on stage should be done. So if it is CAN1, 1 to 3 years follow up. If a CAN2 plus or 2 plus, and then we'll go for a colposcopy. If the lesion is there, we'll go for either ablative therapy or excision biopsy, and they'll be closely followed up. So if we go for a primary HR HPV DNA testing, how to go about it? If it is negative, rescreen. Suppose if it is positive, genotyping we'll see. If it is 16, 18, so they have to go for colposcopy or we'll go for cells cytology. Suppose if it is positive, the other way of going through is you can have a VAA. Suppose you don't have a colposcopic setting, so we can go for a VAA and guided biopsy and triage. The same once we diagnose CAN 1, 2, 3, the same follow-up will be done. Suppose if you are doing only cytology triage, they are negative, repeat HR HPV after 2 years. If it's ascus or more, again we'll be going for a colposcopy. If CAN1 will be a close follow-up, CAN2 plus will go for either ablative or excision and a close follow-up. To summarize, no, actually the cervical cancer, we have a known etiology HPV infection. Modifiable risk factor, awareness is the need of the hour. So, like a primordial prevention, if we make the public aware about the risk factors involved, so we can modify the risk factor. Like for example, people make them using condom, like a barrier contraception can prevent HPV transmission, so that that reduce the risk of acquiring a HPV infection and leading to cervical cancer. And effective vaccination available, so we need to make use of the vaccination. So by making awareness at public places, awareness at school, colleges, so may be of good help. And we have an effective screening method with appropriate treatment for precancerous lesions available. So we have to make use of it. So get informed, get screened and get vaccinated. Cervical cancer can be prevented and treated if got early. So that is a message I want to pass on. To conclude, cervical cancer gives us so much opportunity, so many times it gives. I think so. We have a primordial prevention, primary prevention, secondary prevention. So it is a preventable cancer, effective vaccination available for primary prevention, effective screening available for secondary prevention, effective treatment for precancerous lesions available. And if we detect a cervical cancer early, we can give a 100% cure. So cervical cancer gives us so much opportunity for prevention. So we have to make the use of it. Thank you. Any questions? I am here to answer.
Thank you, madam. Madam, your moderator, your input, madam. We will go to the question next.
Okay. So thank you, ma'am. Wonderful presentation. Anyone have any other questions regarding prevention of cervical cancer or cervical cancer?
I'm looking at the.
Regarding vaccination to be kept in our universal vaccination program, we should, I think, right from our IMA chairman and president also to Prime Minister that it has to be included as soon as possible. I mean, implemented, because now the vaccine is available at the cost of just 300 rupees only to government. They are going to supply it to 250 only, I believe. So I think now we have indigenous vaccine, which government has already allocated budget, and President of India has already symbolically launched it. But it is not yet available in universal immunization program. So we should, I mean, our chairman and our president should request the government, like especially Prime Minister, right to Prime Minister, that this vaccine should be made available as soon as possible in our universal immunization program.
I want to pass on one message, sir. Actually, all the ESI card holder, they can get the free vaccination done at ESI hospital. It is available, sir. Quadrivalent vaccine is right now available with all the ESI hospital. So the staffs who is having a ESI card, they can get vaccinated there for cervical cancer. It is available free of cost for them.
So even in charitable dispensaries, they have free vaccine, madam, in Chennai.
Okay.
At Ramakrishna Math Charitable Dispensary, we have the free vaccination.
Okay, sir. Thank you.
Dr. Ramanan, oncologist.
CGHS and all other railways, every other place it is available. But in universal immunization program, if it is made available, it will be more useful, I feel, because all other vaccines they are getting it through government supply. So if it is already President of India has launched it symbolically, only making it available is only the thing which the government of India should make it speedy. That's what which the budget is also allocated in the interim budget. Budget is also allocated. Only thing is that delay has to be avoided for making the vaccine available in the universal vaccination program. So this lobbying would help. That's what I mean to say.
Madam, we'll go to the question section, madam.
Yeah, yes,
question.
sir.
If the grandma had the carcinoma cervix, whether the grandchildren, females aged more than 40 years, the care need any need of HPV vaccine?
Actually, HPV is not a genetic cancer. It is caused by a viral infection. So any woman have a risk of acquiring infection. So whether the family people have a cervical cancer or not, they can get screened with the HPV. If it is negative, they can go for a vaccination, sir.
Do boys need the vaccine to prevent the large bowel cancers in future?
Actually, large bowel cancer, this is causes penile cancer and anorectal cancer, actually. So, like a HPV virus causes squamous cell carcinoma. It is associated with squamous cell carcinoma. I think boys also should get vaccinated to prevent the chain of preventing cervical cancer, sir.
So actually, for boys also, in foreign countries, they have this vaccination program for boys also. Actually,
age
in India,
limit, madam, for the boys, any age specific age group for the
9
boys?
to 14 years. Same.
9 to 40 up to 26 years it is available, sir. I think WHO recommendation up to 26 years, sir.
Madam,
So
you
basic-
have put as 9 to 14
I
and
put the
15 to
schedule.
26 also. You have put
Yeah.
the schedule also, madam.
Yeah.
So basically, 9 to 14 years, why they are choosing it's the vaccine should be introduced before the first sexual activity. So that's the main criteria. So that's why they have started as 9 to 14. Otherwise, even after that also we can give if they are not exposed to HPV infection.
So
actually, how many doses are to be given, madam?
So actually, they say actually 3 doses, sir. Actually, so 9 to 14 years, 2 doses. 15 to 26 years, 3 doses for boys.
Any need
Girls,
for
I think below 15 years, 2 doses. Above 15 years, we get 3 doses, sir. That's what I have put
That
the
is-
schedule there.
that is
I have screened it.
Before marriage, they have to take it. That means before marriage, they need to take it.
Yeah, before marriage, and I think like even people who is sexually active, what we do a HPV screening test. If the HPV screening test is negative, we'll ask them to go ahead with the vaccination, sir.
even for the men more than 40 years, madam?
26? Why it is mentioned as 26 years?
I think that to make the maximum resource available to people, sir. I think like they have made it like that way. First they want to. I think the WHO aim is they want to eliminate cancer by 2030. So they want to have the younger population fully covered.
Whether male adult population needs more than 40 years
Basically,
in
sometimes
vaccination, madam?
menstrual poor hygiene also will have this HPV infection. So that is also reason why 15 to 26 years of age they need extra dose because they have other things.
Madam, is there any marker to say the efficacy of HPV vaccination is successful?
I think the future data only has to tell us, but so far, whatever they have conducted study, it says that it is effective, sir, 100% effective.
இல்ல எதை வச்சு அசஸ் பண்றாங்க அகாடமிக் பர்பஸ்க்காக?
They do the screening program. That's what I told. No, sir. Even they get vaccinated, so they have to undergo the screening. It is not the end card actually. So they need to go for a screening program. Even once they become sexually active, they need to go for the HPV screening or pap smear screening up to the age of 50 years, sir.
Okay, thank you, madam. Well done.
Madam, but the percentage of protection is 100% as per your statement, whether all the patients received the HPV. Is there any patients already received HPV develop cervical cancer? Do you have the data?
I think the data is not yet available, sir. I think the time only has to give us answer. Like I think it is available 10 years. I think if you see the cervical cancer thing going through, actually, the precancerous lesion itself lives for 5 to 15 years before changing into cancer. So maybe next decade we'll be getting I think a very good data regarding how it is because the vaccination now only more acceptable is available. So Indian data I'm telling.
Any
I think
booster dose
unless
of
if you have
HPV,
any
madam?
information, you can pass on actually. Yeah.
Now the efficacy is mentioned in the form of antibodies. Serum antibodies are measured. I've been part of that trial of vaccination in our Kakinada national trial. In that, there are people who have received only single dose also. That antibodies of single dose vaccination is also equivalent to 2 doses and 3 doses. So the efficacy is measured in the form of antibodies. So as on now, we have the efficacy measured in the form of antibodies, and till date, to best of my knowledge, there's no one who has been affected with cervical cancer who has been vaccinated. In men also, 40% of oral cancers, HPV is the cause. So this vaccination trials for men are been going on in most of the developed countries. Soon this approval for men to be given universally would be coming shortly because 40% of head and neck cancers can be prevented by HPV vaccinations, especially oral cancers.
Thank you for the good information, sir. Madam, the next question, any role of stem cell therapy in the carcinoma cervix?
No, sir. There is no stem cell therapy for carcinoma cervix. See, carcinoma cervix, ideally, if the lesion is visibly like more than 4 centimeter lesion, better go ahead with radiation.
Absolute contraindication for the HPV vaccine?
Immunosuppression, basically, like for those patients who have a retroviral positive, they usually don't recommend HPV vaccine because that's the only thing. Otherwise, no absolute allergic. We don't know. So that is the thing. Otherwise, no.
The patient on some other cancer in the same patient, is it contraindication?
No, 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 no.
Okay.
See, basically, this HPV vaccine has only 4 viruses, quadrivalent vaccine. But the cervix cancer can be caused by, there are other type of HPV subtype which can cause cancer also. So that's why even the after vaccination screening is recommended, because it is only preventive against that particular kind of HPV type. Whereas the remaining subtype can cause cancer for the other patients. That's why even though the HPV vaccine is given, the screening is recommended. It's like pap smear, all those things. So HPV vaccination alone cannot 100% prevent cervix cancer, but it can prevent cervix cancer due to that 4 subtypes. And regarding the oral cancer, it's a oropharyngeal cancer which is due to HPV. So in most of the developed countries where the oral sex is very common, there the oropharyngeal cancer's incidence also more. But whereas in India, oral cancer is mainly due to tobacco. So due to HPV associated oropharyngeal cancer is still less compared to the other developed countries. So HPV vaccine highly preventive for oropharyngeal cancer, anal cancer, penile cancer. These are the 3 cancer. In men, it is preventive.
Is the screening mandatory before vaccine?
No, actually, screening to be started 3 years from the first sexual activity, not immediately. So it's basically the cervical cancer screening to be started from the 3 years of the from the first sexual activity.
In MNJ Institute of Oncology and Regional Cancer Center, one of my PG has done thesis of HPV related oral cancers. The incidence in India is also similar to that one, but we don't have large scale data because single institute studies at MNJ, the data is equivalent to Western data. But as pointed out, in India, we have mostly tobacco related cancers. So that is the main tobacco and alcohol related cancers. So our aim is to control for oral cancers, tobacco and alcohol. But incidence wise, in a single institute, MNJ, Institute of Oncology and Regional Cancer Center, that when we have done, one of our PG has done the thesis of HPV in oral cancers, it was similar to the Western data, but large Indian data, large population based data, we don't have.
Any
Madam?
other questions?
Yes, madam. You can give your final comment. We will close the session. Next, we'll go to the next session.
Madam, sir was telling about the antibody test for this HPV vaccine, no, madam.
Yes,
where
sir.
it is available in our Tamil Nadu?
So basically, any vaccine, the antibody will develop. There is no such regular test to detect the HPV, to see the HPV antibody. It is still under the experimental thing. It's not into the practice. Just the HPV vaccine is currently in the practice. No one is doing HPV antibody to see whether the vaccine is working or not.
What is
Because,
the cost of HPV vaccine, madam? No?
sir,
For any vaccine, say if XYZ is developing a vaccine, we will measure the antibody levels in the serum. Any vaccine. That is what, how the, like say for COVID antibodies we test. Or like that, any vaccination, this is done by the vaccinology, this is not a commercial testing which would be available over the market. It is done for that particular vaccine, that particular trial. Before the drug controller of India or FDA gives approval, they will see how much antibodies are produced by giving the vaccination. This is for the efficacy of vaccine. This is done. This is not over the mark. Like any diagnostic centers will not be normally doing this particular test because that kit itself would be costing more. So those things would not be available for. We have only HPV positivity or negativity testing available, but that cost also is more than the vaccination itself. That's why we are not doing any antibody titers of HPV before giving HPV vaccination, because the vaccination itself costing is less than the testing amount. The recommendations are not to test before vaccination, because the testing cost is more than the vaccine cost, and the side effects, even though if the woman or men is affected by vaccine, there's no harm in giving vaccine. That's why we don't recommend testing before vaccination.
Thank you, sir. Jairam, sir, shall we go to the next session?
Madam, conclusion.
So thank you, Dr. Indraman, for the wonderful presentation. She highlighted all the importance of screening, vaccination, prevention also. And thank you for the wonderful discussion.
Thank you, madam. Thank you, Dr. Indra Nirupatan, madam, for the wonderful giving the object to the excellent presentation, and well done, moderated by Dr. Anbarasi, madam. And especially thank to our Dr. Srirang Akbari, sir, for giving more input to this subject.
Thank you, Dr. Sairam, sir. Sorry, because I've been using that laptop and from the office, that name has been reflected.
Okay, sir. Thank you, Sairam, sir.
I'm Dr.
Thank
Sairam,
you.
sir.
Yes, sir. We'll go to the next
I'm
session.
a clinical oncologist, sir, at MNJ Institute of Oncology, and I'm senior faculty at MNJ Institute of Oncology and Regional Cancer Centers. That's why I could give more inputs about cervical vaccine.
Thank you, sir. We'll go to the next session, sir. The next topic is the current scenario of leprosy diagnosis and management. The moderator is Dr. Pavitra Gunasekharan, and the speaker Dr. Dinesh Kumar. Pavitra, madam. Very much pleased to introduce Dr. Pavitra Gunasekharan. He's a consultant dermatologist and venereologist in RSDX Hospital, Whitefield, Bangalore. She studied MBBS from Keelback Medical College and MD from Madurai Medical College. She previously worked as an assistant professor in the ACS Medical College and Hospital, Chennai. She authorized many chapters in various medical textbooks. She's published many journals in national and international papers. Welcome, Dr. Pavitra, madam. Continue to introduce the speaker. Dr. Yes, Pavitra, sir. Over to you. Kindly share your screen, madam. Now. Yes, sir. Ask the speaker to share the screen. Introduce Dr. Dinesh Kumar, madam.
Yes, sir. Good afternoon to all. I thank the Indian Medical Association, Tamil Nadu State Branch, and its office bearers, especially the Academy of Medical Specialities, for giving me this opportunity to moderate the session on current scenario of leprosy, diagnosis, and management. It is my great honor to introduce the eminent speaker of this session, Dr. D. Dinesh Kumar, MD, FRCP Glasgow and London. He is the president of Indian Association of Dermatologists, Venereologists, and Leprologists, Tamil Nadu branch. He is the first Indian to be selected for the Young Dermatologist Achievement Award by the International League of Dermatological Societies. He is Young Cutaneous Surgeon Awardee 2023 by the Association of Cutaneous Surgeons of India. He is managing editor of IJDVL and chairperson IADVL Standard Operating Procedures Committee. He was General Secretary of IADVL, ACSI, and International Society of Teledermatology. He is an honorary distinguished fellow of Global Association of Physicians of Indian origin. He was awarded the Dowling Club Scholarship by the Dowling Club, an affiliate of the British Association of Dermatologists, to attend clinics in the United Kingdom. He was invited as speaker in various world congresses of dermatology. Okay, so before handing over the mic to the speaker, I would like to say a few introductory words about leprosy and World Leprosy Day. Leprosy, as we all know, is a disease of antiquity, which is known for its debilitating effect on the people affected by it. And this debilitating effect is more so because of the stigma experienced by these people. The World Leprosy Day is observed internationally on the last Sunday of January. It falls on 26th this year. In India, it is always celebrated on the 30th of January to commemorate or honor Mahatma Gandhiji, who was himself a very strong supporter for the rights and respect of people afflicted with this disease. So I now hand over the mic to respected Dr. Dinesh Kumar to present his speech and to enlighten us this knowledge on this subject. Over to you, sir.
Very good afternoon, everybody, and a very happy New Year. Thank you, Dr. Pavitra. And I must thank Dr. Jayaraman sir for the opportunity to talk on leprosy. The month of January being where we observe the World Anti-Leprosy Day, the Martyrdom Day of Gandhi. on the January 30th. So it's very apt that we share some knowledge and about leprosy, a disease since we have known since prehistoric times. Leprosy as a disease is been there for a long time, and the biggest problem with leprosy is the stigma or the exile that the people endure and the feeling of unwantedness. Yeah. So as in the initial part, our president-elect, Dr. Sridhar was talking about, we have a very, very long way to go. Still close to 2 lakh cases are being detected every year. And if you look at this, nearly more than 1/3 of it are women, and also children occupy nearly 5.6% of these cases. It's not only the cases of leprosy which are being detected, but also deformities. Nearly 10,000 new cases of the deformities and nearly 300 children with deformities are detected every year. Most of these cases worldwide are from sub-Saharan countries, the African countries, and also from Southeast Asia, which includes India, Nepal, the neighboring Nepal also. In India, we are seeing progress. We are seeing the prevalence rate of leprosy come down to 0.45, and also the annual new case detection rate come down. But still, we have a very long way to go. The prevalence rate in Tamil Nadu as of now is 0.3 per 10,000 cases, which is reasonably good compared to other states which show like Chhattisgarh 2.3, but still we have to attain what is 0 or at least 0.1. Now, whenever a leprosy patient comes, generally they come with most often skin lesions. The skin lesions could be red, or it could be a less pigmented skin lesion, a dry skin. Generally, some people just come with a simple complaint of loss of hair or loss of sweating, sometimes even nodules or just a presence of a shiny skin. Some people also do have nerve symptoms like either tenderness, tingling sensation, loss of sensation, and motor weakness, like not able to hold a paper or a pen, and not able to hold on to slippers also. Very rarely do these patients come in advanced cases like blockage of nose with ocular symptoms, or also even loss of eyebrows also. So this is what we look into a patient by taking the history. Now, let's go into some basics about leprosy. Leprosy, if you look at leprosy for the major part of the history, leprosy was taken to be a curse. There was no real known cause of leprosy, but everything changed in the year 1873. A Norwegian physician, Armor Hansens, he found out that they were acid-fast bacilli in his microscope, and that leprosy is one of the earliest disease to have an infection tag associated with it, that is to be caused by infectious agent. So Mycobacterium leprae is the causative agent here. Leprosy is not a very highly infectious disease, we need to understand. It is transmitted, and surprisingly, though it is a skin disease, it is transmitted via droplets. The droplets could be nasal secretions, or sometimes even the secretions of the skin. So this is basically, it comes through the aerosol transmission, but sometimes it also comes with people living in close contacts. It also comes, and inoculation also, there have been cases of leprosy being transmitted. There are cases of leprosy being transmitted in utero. Now, regarding cases of leprosy being transmitted via breast milk, the viable bacilli is transmitted through breast milk, but how much this bacilli is able to infect the child through the oral route is a question. So that is not taken much into consideration, and in fact, the WHO also advocates a person with leprosy and on MBMDT to continue feeding the child because that is more beneficial. As previously told, leprosy mainly affects the skin and nerves. Now, the problem with leprosy is if it is left untreated, there can be progressive and permanent damage to the eyes, nerves, which can result in deformities. We need to understand that leprosy is totally curable, and the treatment should be provided in the early stages so that the deformity or the disabilities are also averted. Now, for the ease of treatment, the WHO recommends the multi-drug therapy, which is safe and also very, very effective. And here, a point to note is that once the first dose of the MDT is gone, the patients are no longer infectious. This is something which we need to remember. Now, what happens when the lepra bacilli enters into the body? Now, when the lepra bacilli enters into the body, there's going to be immune reaction as with all of the infective organisms. But what we need to understand here is the response of the immune system is what determines the clinical spectrum of the disease. For example, I'm sorry. Right. For example, when the immune cells, they try to mount a very good attack, basically, then what happens is there's collateral damage of the sweat glands, hair follicles, and the nervous system. And then the body's immune system gently takes over. This is one spectrum of the disease. The other spectrum of the disease is where the immune cells are not able to combat the lepra bacilli, and also the bacteria multiplies freely into the skin, resulting in the various deformities and other clinical spectrum of the disease. Right. Now, this is what I was talking about. Based on the resistance of the body to the bacilli, the spectrum of the disease is determined. So you have a healthy contact who contracts the bacilli, but the body's immune system is so good that they do not show any signs of infection. And then you have the spectrum progressing from there, what is called the earliest signs, the indeterminate leprosy. Then you have the tuberculoid leprosy. Then you have the borderline tuberculoid leprosy. These are clubbed as paucibacillary. Paucibacillary means less number of bacilli. Then you have the borderline lepromatous and lepromatous leprosy, which is classified as the multibacillary leprosy, where you have a large number of microorganisms in the skin. Now, the classification widely accepted is the Ridley-Joplin classification in 1966, which came what I discussed just now. In the Ridley-Joplin, we do not have the indeterminate leprosy. We have only the paucibacillary of TT and BT, and the borderline lepromatous and lepromatous leprosy come in the multibacillary. Now, WHO has classified into two types for the ease of treatment world over, because most of the time the treatments are done by the grassroots workers. So paucibacillary leprosy, which is up to skin 5 lesions, and the slit skin smear negative on all sides, that is failure to show the bacilli on the slit skin smears. And multibacillary leprosy, where you have 6 or more skin lesions and positivity of the acid bacilli. Now, in India, we have a classification which came in the 1950s, and then it was improvised in the 1981, which has this the indeterminate leprosy, tuberculoid, borderline, lepromatous, and the polyneuritic type. Polyneuritic type, I will be talking about it. In this, there is no involvement of the skin, there is only involvement of the nerves. Now, how to diagnose leprosy? Now, as per the expert committee of WHO convened in 2010, a leprosy is a case of someone who has one or more of these signs. That is, any one of these 3 below signs can lead to a diagnosis of leprosy. That is, first is erythematous skin lesions or hypopigmented skin with definite malfunctioning of lack of sensation. The second is peripheral nerve involvement as depicted by explicit nerve thickening or impaired sensation in the vicinity of the lesion or the nerve distribution pattern. And the third is positive skin smear for the acid phase bacilli. You just take a slit skin material from the slit skin from the earlobe or any infiltrate lesion, and if you're able to demonstrate the acid phase bacilli on the microscope, then that also can be taken as a sign. Now, to diagnose leprosy, we need to examine the skin. We need to check for the patches. We need to check for the morphology of the patches. We also need to check for the sensations, the sensory sensation, the touch, the heat and cold. We need to look into the number of patches, the symmetry of the patches, and more importantly, we need to look into the damage caused due to the nerves. In the damage caused due to the nerves, what we are looking is basically, the first we are looking at nerve thickness, where 0 to 3 it's graded, and nerve tenderness, where 0 is no pain and 3 is withdrawal of the limb itself on touching the nerve. And also we also look into the sensory distribution by touch. We also look into the autonomic dysfunction, like lack of sweating, loss of hair, and shininess of the skin. These are the things we look into when we are checking for the nerve involvement, and also the motor involvement, like how a patient is able to hold the pen or a paper in between the fingers. Now, the common examined nerves are generally the greater auricular nerve, the supratrochlear nerve, and the supraorbital nerve, and also the ulnar nerve, the radial cutaneous nerve, the common peroneal, and the posterior tibial nerve. So we palpate these nerves and run our fingers along the nerves to see whether they are thickened and whether they are tender. Now, coming to the first variant, that's indeterminate leprosy. This is taken to be one of the earliest signs of leprosy. It's a very transient, unstable form, and it is bacteriologically negative. That is, the slit skin smear is generally negative. Very unusual to have sensory loss, and most of the time the skin lesions are macular, that is, they just flush with the skin and they just can be a little bit red and with show some loss of pigmentation. Now, it is very, very difficult to diagnose such cases, and the only absolute confirmation for such cases would be demonstrating the acid-fast bacilli in the biopsy specimen in a Phyte-Farako stained sections, and also in a biopsy showing the pre-neurovascular infiltration, that is, infiltration of the immune cells around the neurovascular bundle. Now, a good thing in this intermittent leprosy is if the immunity is very good, most often without treatment, 3 out of 4 cases can heal by themselves too. Now, this is here we see a case where there's just a hypopigmented patch. It's just flush with the skin. There's no what do you say, infiltration, or there's no thickening of the skin or nothing. It's just a simple hypopigmented patch. Now, this can be confused due to a lot of things. A very high degree of suspicion, and a biopsy is only one which is going to help. Again, in this case, such a case where it is just flush with the skin, loss of pigment can be confused with pityriasis alba, a very, very common type of indigenous eczema in kids, or even a polymorphous light eruption. Only with a high degree of suspicion and probably a biopsy can we pick up such cases to be intermittent leprosy. Now, coming to the next in the spectrum, the tuberculoid leprosy, where we see more lesions appearing, 1 to 3 lesions. And here the infiltration starts, because here the cell's immunity starts to kick in. And basically, because there is a very robust reaction, the sensation, or as I was telling you, there's a collateral damage of the sweat glands, the sensations, nerves, everything getting impaired. So there is loss of sensation. And due to a very robust cell-mediated immunity, the acid-fast bacilli are negative here. So again, here we see a raised lesion. A raised lesion is generally a solitary lesion, or less than 3 is indicative of a tuberculoid pattern, which indicates a robust immune system in the patient. Again, a raised lesion, if you see a raised lesion with erythema, most often 1 to 3. The next is a borderline tuberculoid. And as we move from the indeterminate spectrum, what happens is the immunity starts reducing and the bacilli gains upper hand. So here we see a variety of lesions, macular, papillar, or annular. Generally, they are more than 3, and generally they're distributed asymmetrically. And here the important thing is small satellite lesions are present, and there is moderate to marked sensory loss, and generally the AFB start appearing here. So here we see raised lesions, asymmetrical lesions, erythematous, and this is what I was talking about. Satellite lesions. If you see the main lesion and around it, they are small tiny lesions. So such lesions are indicative of borderline tuberculoid leprosy. The next in the spectrum is borderline, that is, it is neither the lepromatous stage or it is in the tuberculoid spectrum, what we call as borderline. So it is an equal thing of tug of war between the immune system and also the bacilli. Macular, papillar lesions are seen. Inverted saucer shaped lesion, I'll be showing them. This is what is a very indicative of this particular variant. More in number, bilateral, but generally asymmetrical they are, and slightly they are shiny. The autonomic dysfunction starts showing in. Sensation is diminished, and here nerve thickening start appearing. And the AFB is moderately positive from 2 to 3 plus bacilli. So here we see the raised surrounding, and the center part is depressed, what we call as an inverted saucer appearance in the borderline leprosy spectrum. The next comes the borderline leprosy spectrum, where you have the bacilli gaining upper hand. You have macular lesions or plaque lesions. Plaque lesions means basically raised infiltrated lesions. Now these are bilateral or asymmetrical, more shiny and less defined. So the definition is not much. In tuberculoid, we see well-defined lesions and with a slight sensory loss over the patches themselves itself, and also diffuse infiltration at certain places. The nerve damage is widespread here, and it can be asymmetrical. Generally, the AFB count is more than 4 plus here. So this is the pattern where you have widespread bilateral asymmetrical lesions. In the lepromatous pattern stage of the spectrum, where we find the bacilli gaining a total hold and running havoc, we have a macular pattern and a nodular pattern. So here in the macular pattern, they are very lots of macules. Macules means basically flat, flush with the skin. There's no elevation, I think. There's just discoloration in the skin, which is seen in this macular pattern. And generally, this skin surface is shiny, and they have a very, very indistinct margin, which merge imperceptibly with the surrounding skin. Most often, they appear erythematous, and also since in the dark skin, they are described as copper-colored appearing. The loss of sensation is not there. The AFB is 4 plus to 6 plus here. So sometimes it's just the macules which are present in the macular stage of epidermolysis leprosy, there's no infiltration, not much or anything here. So it's basically based on the copper colored or shiny skin and with a high degree of suspicion that we pick up such cases. Now in the lepromatous infiltrative spectrum, now here again, it's total havoc. There's diffuse redness of the face. There's a lot of infiltration of the earlobes, extensor aspects of the extremities, lower back. All this may be affected. Initially, generally, there is a little bit fine infiltration, which not much of elevation. Then the patient gets into the post-infiltrative stage, which leads to papules, that is elevation of the skin, plaques, nodules. This is basically because of the aggregation of the infiltrate or the granulomatous formation. So here we see the infiltrate in the skin, in the back. These are raised, ill-defined lesions appearing. Now, these are the nodules seen in lepromatous variant of leprosy. Now, lepromatous leprosy, along with its macular and nodular pattern, is also got something called histoid variant and a lucio leprosy variant. In histoid variant, what I showed previously, there are firm nodules or plaques which appear over the normal looking skin, and these are asymmetrical. Lucio variant is generally, which is lucio basically means a beautiful looking skin, which is a non-nodular pattern, which is generally described in Mexico and Central America. There is a diffuse shiny infiltration of the skin with loss of body hair and also eyebrows and eyelashes, and there's widespread sensory loss in this particular variant. So the histoid nodules here, and these histoid nodules are very fertile ground for biopsy and histopathological studies. Coming to the pure neurotic variant, which is described in the Indian classification. Now, this is diagnosed by excluding presence of any active or previously active lesions and history of previous treatment. So you have to exclude any previous treatment taken and exclude any active skin or previously active skin lesions. Here we have pure nerve involvement with at least one or more nerve thickening with sensory and motor deficit, and a nerve biopsy is generally done to diagnose or confirm such cases. Generally, the nerve stands out as a cord in such cases, a rope or a cord. Now, while managing leprosy, we also need to know what is not leprosy and what are the differential diagnoses which we have to include or while diagnosing or managing a case of leprosy. Generally, non-leprosy cases will have normal sensation. Sometimes they can be present from birth, the nevi, etc. Generally, itching will be present, and they generally have a transient or appear or disappear periodically. And also the spread is very quick. In leprosy, if you look at a leprosy, it's a very slow disease. Even the incubation period generally is 2 to 7 years. It could be a matter of weeks or even 20 years later also patients have picked up. So these are some points which we need to look into to exclude leprosy. Now I'll just show a few of the other conditions which can be confused with leprosy. This is polymorphous light eruptions, which can come as hypopigmented patches over the face, and a classical history of sun exposed areas on irritation on exposure to sun and itching. Fungal infections, pityriasis versicolor, just light colored hypopigmented patches, again asymptomatic, but the fine point here to diagnose is the presence of fine scaling on this, and then you pick up the scales and do a KOH mount. You can pick up the fungi in such cases. Post-Kala-azar dermal leishmaniasis in the endemic areas can be through a challenge in between leprosy and PKDL because there is a lot of similarities generally, but generally the staining, the Giemsa stain is positive in the dermal leishmaniasis. Vitiligo commonly misdiagnosed or treated also. There have been cases which we have seen vitiligo, but vitiligo is totally asymptomatic, just depigmentation of skin. There is no hypopigmentation, it is depigmentation of skin. Psoriasis again is one entity which generally can get confused, though the active form of psoriasis is not, but nevertheless there have been mistakes happening. So in psoriasis we have elevated skin lesions and thick coarse scales which appear, and generally notably there can be joint pain also. The subsiding stage of psoriasis, that is when psoriasis is on management, the lesions, infiltration, everything comes down and the lesions start to flatten out. This stage can be easily confused with the Hansen's disease spectrum. So here again, we need to take a very good history. Nodular lesions, post-Kala-azar dermal leishmaniasis, nodular lesions can be confused with epidermolysis leprosy, but here the ear lobules are generally spared in dermal leishmaniasis. That is something we need to keep in mind, and also the it's more of the central face which is involved here. So before we go towards the end, the reactions in leprosy, this is what is a nightmare in managing leprosy at times. Now, whenever there are immunologically mediated inflammation in the skin, nerve, and the other sides, this immune reaction happens. So just give me 1 minute. So we have type 1 lepra reaction, and then we have a type 2 lepra reaction. The type 1 lepra reaction is basically type 4 delayed type hypersensitivity reaction. Type 2 lepra reaction is basically a type 3 immune complex mediated reaction. So these generally prove a nightmare to the treating physician. Generally, these are treated with corticosteroids, or we even give thalidomide. Clofazimine was also given, and also cyclosporin at times, along with azathioprine, we used to treat the lepra reactions. Now, initially, I did tell you that the WHO classification, the paucibacillary and the multibacillary types. Now, this is what is commonly used in the ground field and the ground staff for the ease of treatment and for the ease of diagnosis. And if facilities are available for slit skin smear, all patients are generally with a positive slit skin smear, that is positive AFB, are taken and treated as multibacillary leprosy. Now, the WHO has come out with treatment regimes. If you look at antiquity, chalmogra oil, which was described in Indian texts, was the mainstay for many centuries, in fact, of treatment of leprosy. Then in the 1940s, the promine, which is the pro form of dapsone, was introduced. Then from 1940s to 1960s, dapsone ruled the roost, but slowly people realized that it is not bactericidal, and resistance, because of its solo usage, resistance began to creep in. Then in the 1960s and 70s, rifampicin and clofazimine were introduced, and the Indian scientists and the Indian physicians introduced the combination therapy of combining these three. And then that's when, from the mid 1970s, the real game changer happened. So we have two different regimes for the paucibacillary leprosy, where only dapsone and rifampicin are given, and we have the 12-month regime for the multibacillary leprosy, where the three drugs are given together. Now the government, or WHO, has come out with these blister packs. The red pack is for the multibacillary leprosy, which is a 3-drug regime, and the 2-drug regime is basically for the paucibacillary. If you look at it, rifampicin is given on once a month in these both regimes. So we have regimes, the blister for the ease of distribution at the ground level by the ground health, grassroots health workers. The color coding is done for adults, paucibacillary adults and multibacillary adults, and also for paucibacillary child and multibacillary child. So it's given, and with the patient has to finish the blister pack, give back the empty blister pack, and collect the new pack for the next month. So this ensures that there is compliance, and it is a very good thing that WHO has made this MDT available throughout the world free of cost since 1995, and so far more than 17 million patients have received this MDMTT in the last 4 decades, and it's been running successful, and that's a pretty good initiative. From the Indian side, the government has announced the leprosy Mukt Bharat, that is India free of leprosy by 2030, and we are looking at achieving the target. The impetus is to push us to get it by 2027, 3 years ahead of the schedule itself for the Sustainable Developmental Goals. The government gives welfare allowance of 12,000 to patients for reconstructive surgery, which is again very useful, because some people do end up in disabilities, and most of them are left alone to fend themselves. So this is a good initiative. And this portal, that is Nikusht 2.0, for effective data collection and analyzing output of data in the real-time dashboard at the center, state, and district levels, is made available so that we have a better, robust data. And the National Strategic Plan and Roadmap to Leprosy and national guidelines for antimicrobial resistance surveillance in leprosy. This is something which is again an important thing. Regarding antimicrobial resistance, in the year 2022, I had an opportunity to visit one of the universities in China to talk about this antimicrobial resistance. This is a real threat which is coming up. This is slowly showing up, and this is something we need to be really taking good care. This is important basically because some of the times leprosy is being treated by private physicians by not the drugs what we looked into. Now, if there is resistance, well and good, but sometimes random drugs are being given or multi-drug therapy regimes are not being followed. So this can lead to antimicrobial resistance. So this needs more surveillance and more education to the physicians too. Now, this is again, it's not without challenges. I happen to be the secretary of the Indian Association of Dermatologists, Venereologists, and Leprologists from 2022 to 2023. And at that time, we did find an acute shortage of clofazimine. Now, this was a very avoidable condition. And in fact, we did write to the secretary. I wrote to the government of India, and luckily this issue got sorted out. But here, the issue happened more because of the company level. There were some issues with regards to the company. So as physicians, it's not only important that we treat the patient and we give the right drug and we stay updated with the medicines and the treatment regimes, but it also that we need to take up activism, ensure that our patients are getting the best possible medicines and also an uninterrupted supply of medicines. This was widely covered in the national press also. So to summarize, good clinical acumen is essential to diagnose leprosy. Skin and nerves are affected, so we need to look into one of the 3 cardinal signs of leprosy. Then we can take a call, that is the skin involvement with sensory impairment, then the nerve involvement, and the thirdly is the presence of acid bacilli. So slit skin smear is a very important tool for diagnosis of early lepromatous leprosy, and a positive slit skin smear can classify a person as multi-bacillary leprosy itself. And skin biopsy, not only in doubtful cases, most of the cases, if the facilities are available, please do a skin biopsy and watch out for leprosy reactions. So thank you very much once again for the attention and the opportunity. As Mother Teresa had remarked, the biggest disease facing us is not tuberculosis and leprosy, but rather the the thought of feeling unwanted. So this is what leprosy patients undergo, the feel of being unwanted, being in exile, though being surrounded by everybody. So we need to prevent it by treating them well, by giving them good opportunities and preventing deformities. And as I told you, please remember, after the first dose of MDT, the patient becomes non-infectious. Thank you once again. My email is at the bottom. If anybody would like to personally correspond, I'll be more than happy to correspond with you all. Thank you once again for the opportunity.
Thank you, sir. Thank you very much for the excellent presentation. Moderator, Dr. Madam, you can give your input. Pavitra, madam.
Yes, sir. Thank you, sir. Thank you for the enlightening talk. You have covered all the topics, including epidemiological data, history, clinical features, classification, differential diagnosis and treatment, including that of reactions, and also about the new initiatives taken by the government and other NGOs. So now we open this topic for any discussions. If there are any questions, you can take them.
Yes, madam.
We take melanoma and leprosy, how to differentiate?
Sir?
Amelanotic melanoma and leprosy, how to differentiate?
Sir, it is more of a suspicion, and generally amelanotic melanoma, you will have a solid lesion and a biopsy. Biopsy is the only thing, sir. You have any suspicion, for us, biopsy is the tool. So as I told you, we look for the 3 cardinal symptoms for leprosy. First, look for the skin involvement with sensory changes, and then any surrounding the, for example, you have in your hand, you check for any ulnar nerve thickening or the radial cutaneous nerve thickening, and then in doubt, do a biopsy, sir.
Sir, in India, the occurrence of leprosy is more due to tropical reason or any other reason?
So probably one thing is non-adherence to treatment and lack of information, lack of picking up cases in the early cases. Like if you see, the WHO had declared leprosy as eradicated in the year 2000, that is almost 25 years back. But still we do see a lot of new cases. Migration in the last 10-15 years, there's been wide-scale migration across India. When people migrate, they migrate with the disease, and also the follow-up of the diseases is not gone. And when people stay in, again, close quarters, there's more chances of the spread.
Sir, it's tubercle and leprosy, because both of them belong to mycobacterial family. Does it occur together in a single patient you have come across?
I personally haven't come across, sir.
Okay. Thank you, sir. Well done. Thank you.
Sir, in program conditions, what are all the common drug-related adverse conditions?
Sir?
Drug-related adverse conditions. I think they are meaning that are adverse reactions because of drugs, most probably.
See, with clofazimine, the most common thing is discoloration of the skin. That is something which is very common. But for a leprosy patient, when they are treating the stigma, it kind of fades into the background. And Dapson hypersensitivity syndrome is something we do see at times. But on the whole, it's like given your regular monitoring of the parameters, it's not something which we really worry about. It's like from a cosmetic view, it's more of the discoloration of the skin. And then we have this Dapson hypersensitivity syndrome. Sometimes the challenges we face is the reactions, the lepra reactions. Those are the biggest challenges.
Sir, any role for CD4 count estimation in leprosy? CD4.
Sir, I do remember a study with CD4 counts because with low CD4 counts, the chances are more higher, but more than that, I'm not able to recall the information. But yes, I think there were some studies on that.
Okay, thank you. Thank you.
How long the patient will get to know once the symptoms enter? Physically, how he will get to know how much time he will take?
Ma'am, again, depends on the awareness of the patient. As I told you, it can be a matter of weeks or even 20 years. The average incubation is 2 to 7 years. Now, if the patient is well aware now, as I showed you some of the pictures, they can be just a loss of pigment. That's it. Just a simple loss of pigment. And this simple loss of pigment, this patch can sometimes spontaneously resolve on its own also. Now, if these patients come to a hospital and there's a high degree of suspicion, and so also from the patient, if the patient is from a highly endemic area, then definitely they'll do a biopsy and catch it up pretty early. But otherwise, it's like it's pretty variable.
Even in first 2 years also.
Yeah, it can go undetected for years.
Oh, thank you.
Up to 20 years, they say the incubation period at times.
No, if any symptoms comes, the patient should get to know, no? For that I am asking.
See, the earliest
because
symptoms,
once the lepra enters the body,
the earliest symptoms you're looking at is this, what do you say, skin changes. So how many
one skin changes, how much time it will take?
No,
get
that's
the
what,
skin
there
changes?
is no fixed time, ma'am. It could be a matter weeks, a matter of years also.
Oh, thank you.
Jayaraman, sir, shall we go to the session? Go to the next session.
Yeah, please proceed. Thank you, Dinesh, for the wonderful crisp and clarity with the pictorial representation. Thank you, Dinesh. We'll move on to the next session. Yeah.
Thank you, sir.
One second.
Yeah.
Can I add a few points to the question?
Please.
Yes, I have personally seen patients with TB and leprosy together in ACS Medical College when I worked there. So it is still there. We see both cases together sometimes, but it is very rare. And about the increase in number of cases in recent years, no. So previously in India, they used to do door-to-door screening, and that was stopped after, like, say 2005, when it was said that leprosy has been eliminated at the national level. After that, what has happened is that patients, because of lack of awareness and all these things, the number of patients kept on increasing. That is, subclinical cases kept on increasing. And actually, my senior who studied in Madurai Medical College, they did a study in Alanganallur district in Madurai. They used ASHAs to go door-to-door screening, and they picked up many cases. So it just shows that leprosy has always been there. Because of this lack of national screening programs, in recent years it has increased. And recently, I've seen many, like, multibacillary cases in Chennai, in Avadi, Pattabram, this area. I've seen many cases. So leprosy is still there, and now for past few years, government has reintroduced screening this thing. So probably we'll be seeing less cases. I should say, because of these things, general practitioners, not dermatologists, but every doctor should know about leprosy so that we can bring it down. It lies in doctors themselves only. to reduce leprosy burden. And about diagnosis, the patients, if they have skin lesions, they come quickly. That's what I have seen. But the lepromatous cases where the patients are usually asymptomatic, they take long time. And this is very dangerous because these lepromatous patients only spread the disease more. So this is what we are seeing. And CD4 in leprosy, there is no much data about it. There have been some studies which shows that T regulatory cells are increased in lepromatous leprosy, but other than that, no data. It has been said that in HIV, CD4 levels may play a role in the presentation of leprosy, patients co-infected with HIV leprosy. And even if after treatment, that is after ART, the patient may go for iron reaction. So that's all. So these are the points.
Madam, is BCG vaccination protects leprosy?
It protects to some levels, but in India everybody is vaccinated. Still, we see leprosy. It gives some immunity, definitely.
Should be avoided. I think it's very stigmatizing.
Sorry, I didn't get. Are there any more questions?
Kindly loud, sir. Sundarmurthy sir, you should told something.
BCG da, வேற ஒண்ணும் இல்ல.
Okay.
Okay, sir. Okay, sir. Thank you.
Thank you, Dr. Pavitra.
Yes,
and Dr. Dinesh Kumar for the wonderful presentation. And we'll go to the next session. The next session is the most important one, the need of the hour, the approach to the polytrauma. The session is moderated by Dr. Ram Mohan, and the speaker from Dr. Pleased to introduce the today moderator for the session in approach to polytrauma. Dr. Ram Mohan is an accident emergency physician. He's the head and accident emergency department, MGM Healthcare, Chennai. He studied MBBS from Siddharth Medical College and MD Emergency Medicine in Sri Ramachandra Medical College. He authored many chapters in various medical textbooks, and he is the member and the past president of the Society for Emergency Medicine of Tamil Nadu. He published many journals in national and international papers. I welcome Dr. Ram Mohan, sir. Over to you.
Thank you, sir.
Dr. Raghunandan.
So, I'm very glad to invite Dr. Raghunandan, who is going to speak on approach to a polytrauma patient. We all know that there are talks on cardiac deaths, there are talks on other strokes related neuroemergencies and death, but in India or in the world, the trauma and deaths are very high in number. And here is Dr. Raghunandan, who is a director, chairman of Radimed Hospital, who will show some light he's going to talk about the approach to a polytrauma patient, sir. Thank you, sir.
Anyhow, first of all, sorry for the delay in my side, and I thank IMA, Indian Medical Association, and doctors to give an opportunity to talk about management of polytrauma patient. And it's very relevant for a country like India because the road traffic accident is very common here. And also the way we manage these patients when they come to a hospital following a polytrauma is not up to the standard, unfortunately, so far. We're all very good in individual terms, but when we come to the as a team management, I think we have to improve a little bit more so that we can save these patients in the golden time period of first few hours after any polytrauma. And hence, I'm going to brief about how we manage the polytrauma patient based on the ATLS protocol. I think we all be aware of what is ATLS, Advanced Trauma Life Support, and so this is the expansion, the Advanced Trauma Life Support, which has prescribed many regulations or rules and guidelines how you would manage polytrauma patients when they come to the ER. And also, I had a wonderful opportunity to use these protocols when I was in United Kingdom, especially in Birmingham, where I was working as a specialist registered in orthopedics in the Birmingham University Hospital, which was a tertiary trauma center. So I used to be actively involved in receiving these kind of polytrauma patients and stabilizing them and then managing appropriately. So it is not only ATLS protocol, but also from my personal experience in United Kingdom as well. And so what happens? What is the any risk of death following a polytrauma? Yes, there is. And it is mostly in the first 1 to 2 hours. That is what we call as the golden time period. And usually that happens due to extensive injury to the brain and transection of the brainstem, injury to the aorta, heart, and the spinal cord. And then again, the mortality goes up after the first hour to third or fourth hour, where these injuries can be controlled and the death risk or the mortality risk can be reduced if we appropriately manage these polytrauma patients. What are the most common problems for death in the first 3 to 4 hours is epidural and subdural intracranial bleeding, a massive hemopneumothorax, pelvic fractures, intra-abdominal injuries, and long bone fractures, maybe like, not a single fracture, but maybe couple or 3 fractures. Then the patient is been stabilized, they survive, and there is further increase in the mortality in about 3 to 4 weeks time. That is usually when infection which can set in and lead to sepsis and multiple organ failure. So what we call the primary survey, resuscitation, adjuncts to primary survey, secondary survey, and continue the resuscitation monitoring and reassessment and tertiary care survey, and then finally the definitive care. Okay, so the ATLS protocol or the guidelines do not start in the hospital. They start at the trauma site. That is the most important thing. You can see on the left-hand side where a truck has collided against a car, which is a very small car. And you can see there is a high velocity accident, which is led to almost crushing of the front part of the car. Imagine, anybody can imagine how much damage would have happened to the passengers sitting in the front seat and what kind of trauma they would have sustained. And hence the ATLS or the supporting the patient starts from this site and it continues up to the hospital. So communication to ER is also very important. And also the initial team who goes to the trauma site, namely the ambulance and the paramedical personnel, also they should try to get more information before they reach the accident site, like what kind of accident, whether it's a truck versus car, and whether the front part of the vehicle is crushed and how many passengers were there if they receive a call. So that, when they go there, they're not surprised by seeing the accident and see how they can extricate the injured passengers outside the car, because they are paramedical personnel with an ambulance. They have medical equipments and other things to support the patients. But how to extricate them? So if they knew that this is what happened and if they have a picture as well, then they can inform other people like fire safety people who can come to the site immediately along with the paramedical people, and they have the necessary instruments like gas welders, electrical welders, and tow bar machines to tow away the bigger truck, and then use the cutting machines to cut through the window of the car so that they can easily extricate the injured passengers safely. Once they are extricated, then the paramedical person can support the patients and start reviving the patients. And hence, all this information is very important, and the coordination between various departments is very important. So it's not only an individual person's effort; it's about a interplay of different departments apart from the medical people. And then once the paramedical people receive their patient outside, so they should have what we call a spinal board, where the patient is immediately placed on the spinal board, supine, flat on the back. And they have to immobilize the cervical spine by strapping the head and chin under with a hard cervical collar and immediately clear the airway and start oxygenation. And this is where the revival starts. And once this is done, they are ready to fly back to the hospital. And at the same time, they should know which hospital or which trauma referral center they're going to reach. And they have to inform the team who is waiting in the emergency room, this is what they're going to expect. That is the number of passengers and what kind of accident how severe is the accident, and what is the profile of the patient, and how bad are they injured, and what are the airway and breathing and circulation. They have to inform to the communication to the ER. So these are all the things we have to pass on accurately. If possible, photograph of the accident site. So what happened? So meanwhile, when you receive the information from the ambulance and also the ETA, that is expected time of arrival, at what time period they likely to reach the hospital, like 20 minutes, 30 minutes, 40 minutes, depending on the traffic as well as the distance from the accident site to the referral center. So that gives a time for the hospital to prepare to receive the polytrauma patients. So this is a separate ER bay has to be allotted to that particular patient, and with all the necessary people. Who are all the team who have to be waiting in the hospital to receive the polytrauma patient? The emergency room physician, anesthetist if possible, orthopedic surgeon, and general surgeon. So ideally, 4 doctors have to be around. Maybe 1 or 2 doctors, maybe in the junior level, can be there to help them. And of the 4, 1 can be the trauma team leader. So any one of the 4, the emergency room physician or anesthetist or orthopedic surgeon, general surgeon, all of the 4 would have got already ATLS trained, and they got the ATLS certificate so that they know what to do. So one of them will act as the trauma team leader who will give the orders and guidelines, and the other 3 or 4 doctors will follow their guidelines while resuscitating the patient. Apart from these medical people, there should be enough paramedical people, like at least 2 or 3 emergency department nurses who are trained in receiving these trauma patients, and a radiographer who will be standing by with a mobile X-ray to do the primary series X-rays in these patients. So the key points is we have to have critical aspects of the hospital preparation. A separate resuscitation bay should be available for the trauma patients. And before the patient arrives, the team should check for the adequacy of the instruments and whether they're functioning properly, and whether they are organized and placed strategically so that they are readily accessible, like laryngoscopes, ET tubes, multiparameter monitors, SpO2 monitors, oxygen supply, and suction. And also we need to have warmed intravenous crystallized solutions immediately available for infusion. And also, once you receive and you think this patient have multiple injuries, like, probably brain injury or a cardiothoracic injury, where you don't have a neurosurgical team or a cardiothoracic team, so you resuscitate and stabilize the patient, and then you know where to refer the patient, and hence you need to have a transfer agreements to the next level trauma center. And also, when you see massive big accidents where multiple patients are involved, then triaging is very important, because you may receive about 5 or 6 patients at the same time. So it's very difficult to manage all the patients at the same time. So and hence there will be 4 color code badges are available. One is red is the one which needs immediate treatment. Yellow needs an urgent treatment, but can be a second priority. Green are stable patients, like normal small lacerations or minor fractures, and hence the treatment for them can be delayed. Black is one where the patients are already dead or are almost about to die, and hence they also need not be resuscitated immediately. So red and yellow deserves the immediate and urgent treatment. So thereby you can allot the human resources as well as the available resources to the needy patients who have higher rate of survival. And hence, and then you go to the resuscitation pathway, which is A, B, C, D, E, which is airway, breathing, circulation, disability, and exposure. So airway always comes with the cervical spine immobilization and securing the neck. So coming to the airway, so ideally the trauma team leader should stand above the head of the patient in the trolley. That means you need to have adequate space between the emergency stretcher and the back wall, so that one doctor can stand adequately there, can comfortably there, and then can assess the airway from the top of the patient head. And also he can clearly see what is happening around and who are all standing there to give the orders and guidelines to his team members. So stabilize the spine by holding the side of the head and neck together by his two hands so that it is not moving independent of the body. Then he can open the airway by jaw thrust and chin lift and then see the airway. And he can ask the sister who is there to help him to put a suction drain into the mouth and clear all the saliva and the secretions so that there is no compromise in the airway. So once the airway is clear, if the patient is unconscious, he has to maintain the airway because the patient cannot maintain himself. So they have to put an airway or ideally an intubation. So oral endotracheal intubation with cuffed ET tube is a preferred method. Sometimes if you have cervical spine trauma is suspected, where you cannot extend or flex the neck to see the airway, you may have to do a blind nasotracheal intubation. So you need to have both the ET tubes in hand. And sometimes this kind of scenario you can see where the patient has got extensive head and neck injuries, where you cannot do both the intubation. Then you may go for an emergency needle cricothyroidectomy, and you can connect a high flow oxygen tube to the needle, and it is contraindicated in children because it can lead to subglottic stenosis. Even if this is difficult because of the neck injury, then you may have to directly go for tracheostomy. So as I told you, airway control and cervical spine protection go together. And so hence protection of the C-spine is very important part of the protocol. And neurological examination does not alone exclude cervical spine injury. We need to have highly suspicion about the C-spine injury in polytrauma patients and those patients with head and neck injury and those patients who are unconscious. You cannot rule out cervical spine until otherwise. So how do you immobilize the cervical spine? That we call triple immobilization. So what is it? You need to place a hard cervical collar around the neck, and which is a universal size. So you need not bother about different sizes. It is get an adjustable holes and plugs where you can adjust the length of the cervical spine depending on the length and hard cervical collar. Then the side bolsters. If you don't have any dedicated side blocks, you can even use a 1 liter saline or a half liter saline bottle by the side of the head and neck. And then you have to strap the head and neck at two places. One is the forehead and the other is the chin around the bolsters to the emergency stretcher, so that the head, neck, and body are in tandem or in same line and they don't move independent of each other. And this is what we call immobilization of C-spine in line with the body. So coming to the radiography, what is the cervical spine X-ray you may have to do in an emergency setup? Only two X-rays are needed. One is the lateral X-ray and the open mouth view. So if the patient can open the mouth himself, he can open. If not, then the team leader can do the chin lift and jaw thrust and try to open the mouth and whatever the possible exposure they can have. So what you need to do or look for in the lateral view is the alignment of the cervical spine from the base of the skull up to T1. Ideally, one has to get the exposure. So C1, 2, 3, 4, 5, 6, 7, and T1. And any malalignment of the vertebral bodies, which may suggest any dislocation or subluxation of the facet joint. And also, the prevertebral soft tissue will give an idea whether there is any subtle or hidden injury which could have been reduced during the transport and hence which is missed. So at the level of C3, the maximum soft tissue shadow in front of the cervical spine and back of the trachea is about 5 to 7 millimeters. At the level of C6, C7, it should not be more than 21 millimeter. If all these parameters are increased, then there might be hematoma, which is coming from the cervical spine injury. And in the open mouth view, what you have to see is the C1 facet, C2 dens, and the C2 body. So in this open mouth view, you can see clearly the junction of the dens and the body. because dense fracture may happen in polytrauma patients, and if the odontoid process is displaced because patient is not mobilized properly, that can immediately transect the spinal cord at a higher level, which will lead to immediate death of the patient. So once the airway and cervical spine are secured, then the team leaders should say breathing. Then the doctor or the paramedical person should assess the breathing. So what they should observe is the chest moving normally. What is the rate and depth of respiration? Shallow breathing or tachypnea are okay. And always bear in the mind, airway patency does not ensure adequate ventilation. And hence, unless the airway is taken care of, you should not go to next level of breathing or circulation. So what is the most common problem of hypoxia or tachypnea in spite of an airway and oxygen has been given is the tension pneumothorax. So which is a classical reason where the patient can go down immediately. So what do you do in adults? If you suspect pneumothorax by paucity of the chest movements, hyperresonant note, decreased auscultation of breath sounds, then you put a wide bore needle at the fourth or fifth intercostal, between the fourth and fifth intercostal space, in the middle axillary line, just above the upper border of the rib. Why not on the lower border of the rib? Because lower border of the rib has got the intercostal nerves and vessels, which you should not damage. And hence, it is always at the upper border of the rib between the fourth and fifth rib. In case of children, you can go to second or third intercostal space, but in the mid-clavicular line. So this is how immediately you decompress the tension pneumothorax, and immediately the patient comes out and oxygenation improves. So once the oxygen is stabilized with high flow oxygen and relieving the pneumothorax, you can go to the next thing, which is circulation. So A, B, now C. So what is circulation with hemorrhage control? So they always hand in glove. So it is not like, you maintain some crystalloids and blood transfusion and you stop there. No, you have to identify where the hemorrhage is happening and you have to control the hemorrhage. So always circulation with hemorrhage control. So where you have suspicion of BP is less than 100, systolic blood pressure less than 100, pulse rate is tachycardia is more than 100, then you suspect there is an ongoing hemorrhage. So what is the immediate resuscitation is done by two large IV cannulas, like what we call the gray colored cannulas on either side of the arm or one arm and one leg, depending on the availability of the veins. Then we have to immediately transfuse 1 liter of warm isotonic crystalloids. And before we used to say 2 liters, now they have said 1 liter is more than enough. And take blood samples for cross matching and other relevant parameters, whatever is required later. In the children, you have to give at the rate of 20 ml per kg body weight, not 1 liter, but based on the body weight. So once you give the 1 liter crystalloid, you observe what is happening to the vital parameters. There are three classifications that our observations can be made. One is a rapid response, and they sustain the blood pressure and the tachycardia is under control. That means there is no major ongoing bleeding. Whatever the bleeding has happened, it is stopped, and you have transfused the crystalloid to sustain the blood pressure and the heart rate. So just have a cross match and wait for the next level. And if the initial response is good, but after a few minutes, the blood pressure drops down, or again the tachycardia comes up, then there is an moderate already blood loss has happened, or there is an ongoing blood loss which has to be looked for. And now the need for blood is very high, and hence a type-specific blood to be requested. If there's no response, then massive blood loss has happened, and we need to have a universal donor blood at least to be available immediately. And the surgeon has to be ready for any surgical intervention. And coming to the how to recognize the ongoing bleeding, where it is happening. So most common is intra-abdominal injury and pelvic fractures. The limb fractures, of course, you know very well, unless there is a vascular injury, they are okay. Some blood loss has already happened, but they are all stabilized by themselves. And hence, how do you determine whether an intra-abdominal hemorrhage is happening? What we call FAST scan, which is focused assessment with sonography for trauma. See, any emergency specialist, Any emergency specialist should be trained to do a fast scan in the ER room so that they can see any free fluid in the peritoneum. It's very highly sensitive, but of course, it should be there more than 400 to 500 ml of peritoneal fluid to be detected, and also very highly sensitive, so specific as well. In some cases where there is not much of fluid, where you don't see any positive fast scan, then you may have to do a diagnostic peritoneal lavage to see any blood collection inside the peritoneal cavity. And again, with the blood transfusion, what's it called? Trauma transfusion protocol. You cannot give just like that packed cells or whole blood just like that, because a lot of blood is lost, and there is a dilution factor which has to be counted in. So for every packed cell, you have to give one plasma and one platelet units, and that is the ratio to be given when you replace the blood. So the best indicator for tissue perfusion in trauma is urine output. Best indicator for determining fluid replacement is central venous pressure. So enhanced urine output is also a very important parameter to monitor the outcome of our resuscitation. And also, tranexamic acid can be considered to control any ongoing bleeding. It has been proved that it decreases the mortality in both blunt and penetrating trauma. So how do you give? So you give bolus of 1 gram tranexamic acid intravenous over 10 minutes, followed by the second dose over a period of 8 hours. And these two has to be given within 3 hours of trauma to have a significant effect on arresting the bleeding. The second most common problem where you have the hemorrhagic shock is the pelvic fractures. There are 3 types of pelvic fractures which can lead to a lot of bleeding. One is anteroposterior compression, APC, lateral compression where the force is coming from the side of the body, the initial force, which is the LC. Vertical shear where there's the one pelvis is completely dissociated and moves up and down, of which I think the anteroposterior compression has got the highest risk for bleeding. And because this is called what we call open book, where the symphysis pubis is disrupted and the pelvic bones open around the sacrum like a book, and the pre-sacral plexus gets stretched out and they get torn and then continue to bleed behind the peritoneum and in front of the sacrum, and hence very difficult to control, and you cannot surgically intervene to control them by open surgery. So what do? Some ERs, they have dedicated pelvic binders like this black binder. You immediately pass under the sacrum and then cross over and then strap it in the front of the pubic symphysis and closing the book. If you don't have the dedicated binders, a simple bed sheet can be twisted and formed like a rope and then passed around the same way and then tied across and then clamped at multiple places to maintain the closed book effect, and thereby you control the bleeding indirectly. Sometimes we may have to resort to external fixator being applied in the ER room itself over the pelvic iliac crest, and you close manually the external fixator and close the book, thereby controlling the bleeding. So unless you do this procedure, the patient is not going to have any arrest in the bleeding, and they're going to suffer in the hemorrhagic shock, irrespective of how many blood transfusion you're going to give. And ultimately, they will go for a DIC as well. So once the circulation is under control, then you go to the disability evaluation, which is basically to check for neurological deficits. And you put the Glasgow Coma Scale and eye opening, verbal response, and motor response, where 4, 5, and 6 scores can be given. So out of 15, the cumulative score as well as individual eye, verbal, motor response have to be documented. Once this GCS score is done, then the patient has to be log rolled to inspect the back of the body, where you need to have at least 4 people. One is the trauma team leader who controls the head and neck. The other 3 people will have to roll the body. When the trauma team leader says, yes, go and roll the body, then they all turn the body in tandem. So there is no abnormal twist in the head and neck from the body. And once the patient is turned to the side, then one of the team members have to inspect for any contusion, ecchymosis, or any tenderness if the patient is awake, but to rule out any posterior injury or posterior fractures. At the same time, please inspect the loins to find out any ecchymosis or swelling is there, and find any renal tenderness there, suspecting any renal injury. So once this is completed, they can roll back to the to the board or the stretcher bed, and then again strap the head and neck unless it is the cervical spine is cleared off. So has to be repeated again and again to make sure the patient does not have more injury. So then what are the adjuncts to primary survey? That's a monitoring, like SpO2 monitoring, multi-parameter monitoring, and I have to put urine tube to monitor urine output, and also NG tube if needed. And a chest X-ray also have to be completed at the end of this primary survey, and blood glucose has to be taken. So what next? After primary survey, again you have to make sure the airway, breathing, circulation, A, B, C, again they are being protected and maintained without any compromise. So reassess, if anything is going again down, look into the parameter before proceeding to the next step. And now comes the secondary survey, which is a proper and thorough head to foot examination. Look for any missed small fractures or any dislocations or small lacerations and any other possible problems. So then once you can clean the fractures to control the pain and the small amount of bleeding as well. Then you go for ample history in terms of allergies and as to what medication the patient is already on, any past significant illness, whether if a lady patient, if there's any already pregnant or non-pregnant, when was the last meal taken, what were the events related to injury. Once this is completed, then the tertiary survey will come in, where comprehensive evaluation will be done, thorough physical examination, and in a targeted radiographic imaging, like if you have a fracture of the femur or tibia, you can take an X-ray of the femur and tibia, and that completes the tertiary survey. Now, special mention about ATLS in pediatric patients. There are small variations, like, in adult patient, you can make the patient to fly flat on the stretcher board. But here, since the head is bigger than the body, if you keep it flat, the head is in relatively flexed position, which means you are bending the cervical spine in flexion. And hence, you have to place a small sheet for the body, and then the head should lie flat on the stretcher board so that neck is little extended, so the C-spine is not flexed to protect the C-spine. And of course, airway orotracheal intubation is the most reliable method, and don't try to do surgical cricothyroidotomy unless the child is like adolescent. Otherwise, it may lead to subglottic stenosis. And always fully oxygenate the child before attempting the endotracheal tube. And in infants, you can try to put an uncuffed tube as well because it's quite snug. Only in the children, you have to use cuffed ET tube. For breathing, using a pediatric bag mask is recommended for children under 30 kilograms. Hypoxia is the most common cause of pediatric cardiac arrest. In case of tension pneumothorax in children, as I told before, needle decompression at the between the second and third rib in the mid-clavicular line using a 14 to 18 gauge needle. And in terms of circulation, in infant, it is 80 ml per kg. Children between 1 and 3 years, 75 ml per kg. And children over 3 years at 70 ml per kg body weight. Sometimes it's very difficult to find cannulation in pediatric patients. So in that case, if you have to give emergency replacement of fluid, then intraosseous insertion is another option, where the anteromedial tibia is an ideal site, where you can make a small penetration into the tibia and then connect it to the IV site, and then you can give a large amount of fluid replacement. And also urine output is very important parameter. And for the urine ideal output goal for infant is 1 to 2 ml per kg per hour. For age more than 1 up to adolescent is 1 to 1.5 ml per kg per hour, and 0.5 ml for teenagers or adults. And another special mention for pregnant women. So pregnant women, there's another problem of the fetus lying in the uterus. So if you are expecting the patient to lie on the supine position on the spine for about at least 30 to 60 minutes, which is not ideal because the weight of the fetus and uterus may press the intravenous cava, inferior vena cava, which can obstruct the cardiac rhythm. And hence, it is ideal for the patient to be turned 15 to 30 degrees to the side, and then keep a bolster under the spine, and the patient rests on the bolster rather than completely supine. Thereby, the pressure on the IVC will be relieved. And also, monitor for fetal heart sound if possible with a Doppler ultrasound, which is possible after 10 weeks of gestation. And if it is heard, then you can continuously monitor the fetal heart rate, because fetal heart rate is very sensitive indicator for maternal blood volume as well. So if you can easily hear the fetal heart rate, then the blood volume in the mother is almost good. So there's no need to big worry about that. And there is always a confusion and conflict whether we have to perform radiographic studies in these scenarios. If the patient is critically ill, the benefits definitely outweigh the potential risk to the fetus, and hence we have to perform at least the primary series X-ray, namely the C-spine X-ray, chest X-ray, and X-ray pelvis in the pregnant woman. So once the patient is stable and life-threatening and injuries are sorted out, we orthopedic surgeons can happily take over the patient, do their work on the limb fractures. Thank you.
Sir, well done, sir. Dr. Sundaramurthy here, pulmonologist from Chennai.
Thank you, sir.
So, what type of sepsis you come across?
So, from the sepsis point of view, usually from the abdominal injuries, so in that case is the most common organisms found in the gut. Namely, gram-negative is the most common sepsis we find in polytrauma patients after initial resuscitation and the period of about 3 to 4 weeks. So we may have to give antibiotics to target the gram-negative bacteria. And if it is open fractures, of course, then we have to consider gram-positive as well as anaerobic infections as well.
Regarding blood loss, how useful the plasma expanders? Do you use it till we get the blood, or?
No, sir. What they recommend is only crystalloids, which we have only 1 liter of crystalloids. And then if for critical patients, you may allow to give even a universal donor blood without cross match if the patient is critically ill.
Okay. Well done, sir. Thank you.
Thank you.
And there is a question, Raghu.
Yes, sir.
Is the
Yes,
current ambulance is okay for the trauma management during transportation of the patients, or any other facilities?
The thing is, the ambulance is everything is fine. So whatever the highly equipped ambulance now, with all even ventilators, they come with oxygen, everything is there, suction tube is there, and they have the spinal board is there. But the problem is whether the paramedical people are properly trained in the ATRIS protocol method to approach the patient. And the second important point, what we are lacking is the communication from this accident site to the trauma center. So these are the two important things which are affecting our patients, compromising their safety and life in the golden hour time.
Okay. And regarding any legal issues in trauma management patients, have you come across any legal issues? How do you have managed?
See, like, for example, if you have a big trauma center and you receive the patient, that is fine. But if you not have a trauma center, and if you happen to receive a patient, that is where the problem comes. Okay, you cannot say that the patient cannot be the patient just already in your hospital ER room because somebody has brought or some ambulance has brought because it's a nearby hospital. Like, that is what I'm telling. So the proper lack of communication and established protocol and pathway is not there. That is where all the problem comes in. For example, if I receive where my hospital is not a major trauma center, we do not have such facilities, then what I should do is make sure that at least the airway and breathing is taken care of. And put 2 gray ventilants and put an IV crystallite and immediately transfer the patient to the trauma center. Then you are safe because you have done as a doctor, what you have done is right. But if you continue the treatment where the facility is not enough, then I may be like, maybe ask questions. So why have you received the patient and continued the treatment? So then, the legal issues can come.
You said the first aid, some clinic or hospital is giving the first aid. Whether it is mandatory to put the AR copy, or without AR copy, the first aid they can give the first aid or refer to the higher center. What is the
See,
latest?
first of all, AR copy is not important here. First of all, the patient's life is very important. Okay, so once you receive the patient, ignore the AR copy. Don't rush to fill the AR copy. We have to research. Our aim as a doctor is not legal issue or some other things. Our thing is only the patient care. So once you stabilize the patient, and if you're going to transfer the patient, you can always, after that, sit and fill the AR form because you have received the patient, you have assessed the patient. It's not like you have not assessed, you just did first aid. No, you cannot escape that. So you have seen the injury and how it was there and what is. You are the first person to document that one and seen that one. So you have to document the AR copy. And then, but before that, the patient has to be transported immediately to the next level of care. But you can sit and write all the AR copy and finish within next half an hour and complete the formality, so that you can send a copy to the police station as well as and send one copy to the next referral center as well. So it is clear for them.
Okay, which type of crystalloid is very much useful in patient?
See, the initial stage, even a normal saline, it's more than enough. Okay, what we need is only a volume expander. So we are not trying to sustain the blood pressure and pressure. So until we are finding to control the hemorrhage, that's all our aim. Like pelvic binder. Once you put a pelvic binder, if you give crystalloids, then whatever the BP will not continue to fall down. Then you can always arrange blood depending on what you have and how far you are and other things.
Okay. Any other questions from the audience?
Saying that this mannitol can be given for head injury with unconsciousness.
So I think as a neurosurgeon, you are the best person to answer that question, sir. You're asking the question. Please give the answer as well.
Sir, actually, when we are seeing the patients, mannitol should not be given whatever
Yes.
the stage may be. That is the thing. Only after seeing the CT scan, you are supposed to give the mannitol.
Mannitol.
Only if it is seen as, if the extradural hematoma is not there, you can boldly go ahead and give it mannitol. In the subdural hematoma or diffuse cerebral edema, you can give it, but not routinely. If when the patient is unconscious, we should not go with the mannitol. And also, when there is an injury, the patient may be in a shock and the BP also may be low. At the time, if we give the mannitol, further it deteriorates. That's why mannitol is a double-edged weapon. We should be very, very cautious in giving the mannitols.
Very nice.
Okay,
sir.
thank you.
Very nice. Sir, in head injury point of view, any inputs you want to give, sir? Dr. Rajesh Babu, sir, in polytrauma patient, the priority basis, in the priority basis. Any
Priority
input?
basis means that comes only after diagnosis, no? Once after the screening, and then when we take the CT scan, if the CT scan is showing abnormality and clinically the Glasgow Coma score is very low, first important thing is we need to resuscitate the patient and start doing if it is an injury is a subdural hematoma with the massive shift and all those things there, we need to do the head surgery first.
Okay.
So that's what once a patient is stabilized after the primary A, B, C, D, E, and then then you go for the secondary survey and then focused investigation. That's what I told you, focused investigation. If the patient is unconscious, then the focused investigation has to be CT brain along with the CT spine. So CT brain with the CT spine, which comes together. So that will confirm whether there is any hemorrhage and contusion, and as well as it will give any bony injury to the spinal cord, C-spine as well. So once you know that, then and the other parameters have been stable, then the focus of intervention has to be in the neurosurgical department. So immediately based on the neurosurgeon's criteria, they will shift immediately to theater to decompress the bleed.
Okay, sir. Sir, moderator Dr. Ramohan, sir, please give your input. Ramohan, sir. Dr. Ramohan. Rajesh Babu, sir.
Yes, sir.
And one more question. Can, I think, tranexamic acid be given as the first aid to measure and arrest the bleeding?
Tranexamic acid can be given?
to arrest the bleeding? First aid measure.
Yeah, I mean, in the protocol, I told it has to be given within 8 hours, the first bolus dose, and then first within 3 hours, the first bolus dose, and then followed by infusion. So, because tranexamic acid can increase, particularly the venous bleed and capillary bleed from the pelvic vein injuries, when the bleeding is happening, they can try to improve the clot. But all these things will work only when you try to put the pelvic binder and control the bleeding. Otherwise, these things are not going to work. So that is very important.
Okay.
For limb bleeding, tourniquet is advisable.
So when the limb bleeding is happening, you can apply a tourniquet temporarily and put a high pressure bandage on the top of the wound. And then if you can easily identify and locate the bleeding point in the ER itself, then you can do with a dressing set, you can put a to stop the bleeding. But if it is happening from the inside, then you may have to put the tourniquet and immediately compress with the IV pad and put a tight bandage. And then you may have to immediately shift to the theater once the other airway and breathing are secured.
Okay, sir. Dr. Jayaraman, sir.
Yes, sir.
Sir, shall we conclude this then? Rajesh Babu, sir, any other questions from the audience?
Please call Dr. Ram Mohan for the concluding remarks. Conclusion, Ram, sir.
I'm here, sir. I'm here, sir.
Yeah, concluding remarks, sir. Yeah.
Sir, thank you for your wonderful talk on approach to a polytrauma patient. As you said, yes, it depends on the ER physician and the availability of the surgeons and the early approach, the golden hour. If you can meet the patient on the golden hour, I think we could be able to save many lives. That's really a wonderful presentation. And there are many Thai centers which are doing the great job and across Tamil Nadu. And glad to say that the Tamil Nadu traffic accidents come down. I don't know the percentage, but it has come down drastically thanks to the Tamil Nadu police and their initiatives. And a great initiative is like the Thai centers, which are doing a wonderful job. I have visited all the Thai centers to take the trauma life support program from my Society of Emergency Medicine India. Wonderful setup, like a corporate hospital. Thanks for this opportunity and wonderful speaking, sir.
Thank you. Thank you so much.
Thank you, Ram. If there are no questions, we can conclude the session. Now I'll give my vote of thanks. So good evening to one and all. Thank you for this wonderful evening. We had 3 great talks to commemorate the Cervical Cancer Awareness Week and the Leprosy Day and the Road Safety Awareness Week. We have a star speakers, Dr. Indra Nedumaran from MGM, spoke about cervical cancer prevention, moderated by Dr. Anbarasi. And we have a wonderful session on leprosy diagnosis and treatment aspect. Dr. Dinesh did a wonderful theoretical aspect, and Pavitra introduced the talk and with leprosy, etc. And we had a wonderful talk on road safety, polytrauma, how to approach polytrauma with a multimodality approach. So A, B, C, D, E, and all. Dr. Raghunandan did a wonderful talk. I thank Dr. Ram Mohan for the wonderful moderation. I thank you all the IMA leaders, Dr. Ramnik Bedi sir, and Dr. Sairam sir, our Honorary Secretary of IMA AMS, and our new President, Dr. Sengutuvan sir, and all the leaders of IMA and the delegates for the wonderful session. So thank you all for this wonderful evening. Thank you, technical team, and thank you all. So we'll meet again. So every first Thursday with a different topic. I request everyone, those who are not joined IMA AMS with the PG qualifications, kindly join and start the AMS chapter in your branch, local branch, and you join, you apply the fellowship, FIAMS. So we have annual conferences next year, mostly in Chennai or Puducherry. We are planning at annual AMS conference. So welcome to join all the updates. We are going to start the periodical programs, CME and workshop. So please stay tuned. I'll with that I conclude my vote of thanks. Thank you all for this wonderful evening. So God bless. Long live IMA. Thank you very much. We'll meet again. Thank you.
Thank you, sir.
Thank you.